Hello, Dazzle. Thanks for coming and hanging out with me today. I'm glad that you're here. Today, I want to talk about the complex layers of medical bias. It's a pervasive problem, but it's also really difficult to address because of the way that it is layered and woven into the system. So, I want to talk about some of the reasons that it's hard to address. So the first challenge is that who we physically are is not just about our health. There are numerous biases that are based upon a person's physical being. Things like our biological sex, our race, our weight, our age, are all things that have biases associated with them, like sexism, racism, fat phobia, ageism. But it's also true that these physical differences create different medical risks. And the first challenge is, how do you separate the very real and important clinical reality of medical risk that's based upon a person's physical identity from the terrible and toxic biases that are often also associated with those same traits? So, the first important thing is that just because a healthcare provider is talking about one of these kinds of categories doesn't mean that it is inherently falling into the trap of bias. Discussing someone's risk based upon their physical identity, it's an important part of preventing disease. We want providers to be offering mammograms to people who have breasts, and we want providers to address the fact that African Americans are more likely to have complications from high blood pressures. It's important for a provider to discuss the risk that's associated with a person's weight being over ideal body weight. But all too often, providers cross the line from good clinical practice into biased thinking. And how does that happen? So let's take a closer look at one of the biases to better understand the complexity of how bias plays out in the medical setting. What sex you are born with has a biological impact on your health risk, and it's a very important factor to consider in your health. But there's also the reality of gender bias in the medical system. An example of this bias is the reality that females are less likely to be believed that they are experiencing pain. For this discussion, for the sake of keeping things simple, let's focus on the issue of how pain is managed in the healthcare setting in context of a person's reported sex. The bias that exists regarding sex and pain is present in all of society. Parents respond to male and female children differently when they're in pain. And this means that society has rules for how males and females behave regarding pain that has been taught to all of us. And those lessons begin when we're children and our parents are responding to our pain reports. How our parents respond to our pain teaches us how we should be responding and reporting our pain. None of us are leaving those biases behind when we go to a medical appointment, regardless of whether or not we are the patient or the provider. The majority of the research that has been done regarding pain has been focused entirely on the male experience. It has only been in the last decade that females have been included in this research to any meaningful degree. And this means that there is a foundation of bias built into the medical knowledge, that providers are taught about the pain experience, and the best treatment approaches are based on male experience. And this inherent bias in the system is one that a provider cannot avoid because they can't use medical knowledge that we haven't discovered yet. There is research that reflects that providers are less likely to medicate females. However, it isn't as simple as women not getting pain medication. Research shows that providers are more likely to medicate someone who is the same sex as them. This research also showed that providers tend to give higher doses for longer periods to those of the same gender. And perhaps this means that we have an easier time assessing someone of the same sex as us, but it may also suggest that a long standing polarization and division of the genders within our society has significant impacts on the ways that providers are making clinical decisions. There's also fundamental problems with the manner in which procedures and products are researched and approved. Intrauterine devices, or IUDs, are a common form of birth control. They're a small device that is inserted into the uterus to prevent pregnancy, and they can also be used to help manage numerous health conditions. During the development and approval process of this product, it was never required that the product be evaluated for the possibility of causing pain. Nor was it required to develop methods to treat the pain caused by this procedure once it was understood that it was painful. To date, no preventive pharmacological intervention has been adequately evaluated in a random controlled trial setting and been shown to significantly reduce pain associated with IUD placement. And this means that when providers are considering choosing treatment options for their patients, they may not have the option to give them adequate pain control with those treatments. That limitation is often because of a flaw in the way that products and procedures are developed, rather than the degree of compassion or empathy that a provider might have for their patient. And it puts the provider in the difficult situation of having the best treatment option might also be a source of pain that can't be treated. The biases within our healthcare system are woven so completely into the fabric that there are times that a provider cannot avoid practicing with bias. When they are taught based only on the male experience of pain, because that is all that has ever been researched, they cannot avoid bias. When medical products are not researched or approved without bias, the provider cannot avoid bias. And this means that if we want to remove the bias in our healthcare system, we must begin by looking at the very roots and foundation of that system. And this isn't to say that a provider can take steps to reduce the amount of bias in their practice. They can put protocols into place so that every patient that comes in is screened and treated similarly. They can be mindful of their own personal biases and strive to not allow those biases to cloud their decision making. They can strive to create collaborative relationships with their patients rather than one of paternalism. They can create an environment that encourages a multidisciplinary approach, which can reduce the risk of bias by increasing the number of providers assessing the case. And what can you do as a patient? It's important to understand that bias is woven into our system, and because of that, it can't be avoided. So advocate for yourself. If you're unable to do this, find an ally who can advocate for you. And if you have someone supporting you as an advocate, consider making them your POA as well. If you don't know anyone that you can trust to do this, consider finding a professional health advocate. If you don't feel a provider gave you adequate care, get a second opinion. Be aware of your own biases and trauma responses that might impact the conversation. In the end, if your provider isn't helping you find wellness, it's time to find another provider. Well, that's about it for my rambling today. Thanks for coming and spending time with me. If you like my rambling, then click on that like button. It really does help. And until we talk again, you guys take care of yourselves. Bye.